Hi, I'm Liz.
Hi, I'm Josie. We're both practicing nurses in Massachusetts, and we're also nursing faculty at Endicott College in Beverly.
So I've held many roles in nursing education, including administrative roles, and I've worked with accreditation.
And I've had a lot of different roles in nursing leadership. I've done some staff education, and I've had supervisor roles.
So I don't think it's a secret that novice nurses, when they enter into practice, are not prepared, and there's a lot of research to support this. So we recognize that we, with our combined experience in both practice and education, have some expertise in looking for innovative ways to prepare new nurses for practice.
New nurses are expected to hit the ground running right now, but there's not resources like there once were to support them when they get to practice. Experienced nurses are leaving the profession, and we just don't have enough educators or preceptors out there in practice settings. So new grads really need to be confident in their clinical judgment skills before they get there.
So with the recent focus on clinical judgment in nursing education, we saw that clinical judgment was being emphasized, taught, and measured pretty effectively in the high fidelity simulation setting, as well as in the clinical setting. But what happens when you're in the classroom, the traditional classroom with 30 students in front of you and one faculty member? How can we continue to reinforce that learning in that environment as well? And that's sort of what started us on this path. So we created a course model based on Chris Tanner's model for clinical judgment.
Since we're both still practicing nurses, we really knew that Tanner's model captures the way that nurses think better than any framework we've ever seen before. We think it really makes the implicit work of nursing explicit in a way that it can become tangible to a student and describes clinical reasoning in a way that a novice nurse can really grasp.
So the challenge for us was to take our traditional classroom space and turn it into a practice environment. So what we did was we created a model for teaching that allows students to pull forward prior learning, learn about new concepts, and then practice applying them to a case scenario in the classroom setting. But we did it in a way that kind of facilitated the clinical judgment and the critical thinking that happens when you care for an actual patient. So students participated in a weekly activity using a low fidelity simulation video to promote their clinical judgment development. A client report was recorded by either myself or by Josie, serving as the nurses. We reported off to the student as if we were giving a patient handoff. The student listened to report. They wrote down important information, questions that they wanted to ask, things that they wanted to learn more about, and they started to cluster that information together to form a picture of what they expected to do with that patient during their shift. After they finished the report, they then did some research where they looked up diagnoses, medications, nursing considerations related to what they heard on reports, so that they were really prepared when they came into class to take on care of the patient.
So in the classroom, we put students into groups where they assumed care of their patient. The groups took turns choosing actions to implement in a video case study. We really encouraged other groups to offer additional suggestions during that discussion. And what we wanted to do here was to promote teamwork and collaboration. We really feel like this is a realistic and useful practice skill. The progression of the cases really does become dependent on the students' choices. So as faculty, we facilitated the case, but students were prompted to make new clinical judgments based on changes in the client's condition. We sometimes even offered clinical curveballs, we called them, to promote this ambiguity. What we wanted to do was encourage the student to reflect in action and promote flexible thinking. Sometimes the outcomes were positive, sometimes they weren't, and we rolled with it. Regardless, the students were asked to engage in reflection on action via a discussion post following each simulation.
And the reflection on action was really one of the best parts about this course, because it gave us a chance to read their responses and kind of see that evolution of confidence over the course of the semester. So we prompted the students with questions to reflect back on the case. What went well? What didn't go well? What would they do differently next time? But what we found the students were using the post for mostly was to sort of talk about how their thinking has changed over the course of the semester. Their confidence was growing. They were reflecting that there were many appropriate actions in a given situation, and sometimes focusing on trying to find the best action was actually the thing that slowed them down. And what they really wanted to get better at doing was looking at the entire picture and making an appropriate action based on the scenario, recognizing when something was going wrong, and then coming up with an appropriate action to address it. That was one way in which we assessed the students' learning, but we also recognized that we needed to find out if they were becoming, better at clinical judgment over the course of the semester. So we did have 2 objective exams within the course, one at the midterm point and then one at the final exam point. And these were case-based, evolving scenarios where students made decisions based on what was happening with the patient. And all of the questions were modeled after the next generation NCLEX examination to give them practice with that format of questions. The students performed extremely well as a group, but they saw a significant increase in their performance from mid-semester to the end of the semester. And the other thing that we assessed was their confidence. So we gave them confidence questionnaires a few times over the course of the semester to look at the different phases of the clinical judgment model to see if they were getting more confident in each one. And overwhelmingly, the students said that they were. They felt far more confident speaking up, taking an action. They felt more confident collaborating, saying when they didn't know the answer to a question and asking for help. And those were all things that we think really speak to the focus on patient safety that comes out of these activities. The last thing that we assessed was, the students' perception of their learning. And we did that with course evaluations at the end of the semester. So the students completed those. And what we did was qualitative analysis, essentially, and we looked at the comments. And not only did the students find the course was challenging, engaging, rewarding, but they were saying things like, this is the first time that I've really felt like I'm thinking like a nurse. I'm no longer looking for the right answer every time. I'm taking all the things that I know and making an appropriate action based on that information. And we felt that it was the first time that we had seen in our students really their ability to think like a nurse. And again, a reason why Chris Tanner's model of clinical judgment feels to us like the closest thing to what we actually do as practicing nurses in the field. And we definitely saw that in our students as well. And most importantly, they saw it in themselves.
So if you want to try this out in your classroom, Liz and I both believe that one of the most important things that you can do is to make your classroom a really safe and judgment-free practice space. The relationship that the educator has with their students is really what allows the student to be able to learn from their mistakes. We really feel like it's important that they can't be afraid to fail with us.
We also think it's important to guide your students to understand that there is more than one way to approach a problem. They get so hung up on looking for the right answer that they become paralyzed and they cannot take an action at all. And when you think about errors in patient care and failure to rescue, it's really important that they have that confidence to take a step. And if they don't know what to do, asking for help. So allow them to make their own decisions, give them the chance to defend those choices and give their own rationale. And then educators can present themselves more as a guide, offer evidence-based suggestions, encourage discussion that drives the students to connect that concrete knowledge to practice, and then allows them to make more comfortable decisions in the moment.
And we really think, most of all, just be flexible and have fun. This activity really has the most value when the educator themselves has the ability to cope with ambiguity and is willing to facilitate learning in whichever direction the student chooses. Nurses have a unique opportunity to connect with individuals. And we know that a one-size-fits-all approach is just not going to work in patient care. It's not going to work in the classroom either. The ambiguity and the flexibility that keep our practice exciting are the things that we want to model for our students. We're the coaches that can share that with them. And we just want to remind you, don't forget to model that joy.
So the best part about this activity is that it can fit into really any course in a nursing curriculum. It can be a one-day activity that you do, or it can be like Josie and I did and structure an entire course using this model. You just have to adjust the content that's being delivered. It doesn't require a lot of resources, and it can be done with a large group, which is nice. So students, like I said, found it both challenging and engaging. They felt that they were really thinking effectively during this process. They got a lot out of it. So we really hope that you try it out out, and please connect with us and let us know how it goes. Thank you.
Thanks.